Hi guys, this is our final physio review for exam 2, HBF2, on lecture 41 through 43. Hopefully this won't take too long, but it is on about 60 pages worth of lecture material, so we'll do our best. All right, so for the first one, we're concerned with GI motility, so the passage of food through the GI tract. And so we started off by talking about really the cells of the GI tract. And we have our epithelial cells along the GI tract, which are involved in secretion and absorption. And then we have the muscularis mucosa, which is going to have contractile properties, change the surface area, involved in secretion and absorption. We have our circular muscle, which is going to change diameter, help propel food through the GI tract. And then same thing with the longitudinal muscle, shorten the sections of the GI tract to get movement of food through it. Then we have the submucosal plexus, aka mesenteric plexus, and the myenteric plexus, which both make up the enteric nervous system of the GI tract. And so the integration of the submucosal and myenteric plexus is going to control motility and then secretory and endocrine functions. All right, so we had a couple of clinical significance already, correlations. We'll look at those a little bit later on, but really what we're going to be doing is focus on peristalsis quite a bit. And so basically we have our two smooth muscle layers, our circular layer and then our longitudinal layer, and then the circular layer is going to contract to propel our boluses forward, and then a longitudinal layer is going to contract to shorten the intestine. And so really you can see, throughout the layers of the GI tract, we have the smooth muscle layers, and we have our circular layer, more internal, and our longitudinal layer overall. And you can see that we have the enteric plexus or myenteric plexus, and then the submucosal plexus overall. All right, so then that brings us, we kind of skipped ahead a little bit, but the basics of GI mobility are contractions of the GI smooth muscle are going to cause motility, and it's almost all due to the smooth muscle, longitudinal and circular, with the exception of in the pharynx, aka the throat, the upper 1/3 of the esophagus, and then the external anal sphincter are going to use striated, aka skeletal muscle. So the upper 1/3 of the esophagus, the second third of the esophagus is going to be a mix of striated and smooth, and then the muscle cells, the smooth muscle cells are connected by gap junctions, which is going to be important in transmission of our action potentials. And then we have depolarization of these circular smooth muscle cells is going to cause contraction of the smooth muscular ring, right? We saw it here, and decreased diameter. And then depolarization of the longitudinal smooth muscle is going to decrease length, help propel the bolus of food along, aka the bowl of food, and then actually increase diameter to, why would that be helpful? Well, increased diameter would make it easier for food to move, or bolus to move. All right, so then we started talking about the nervous system in the GI tract, and specifically for, we have the concept of slow waves. And so the myenteric plexus that is, in between these layers of smooth muscle is going to initiate slow waves, which are spontaneous, kind of like the pacemaker cells we saw in the SA and AV nodes in the heart. They're called the interstitial cells of Conjol, the pacemakers for the GI tract. They determine the pattern of contraction. Specifically, they do not cause the action potential, but they get these smooth muscle cells very close to the action potential. And so you can kind of start to see that here. This is the slow wave originated by these interstitial cells, which you can see are in our myenteric plexus above our smooth muscle cells. And they are going to set the maximum frequency at which any section of the GI tract is going to contract overall. But you still need those gap junctions between the smooth muscle cells to cause our muscle cells to contract, right? These slow waves will get you close to threshold, and then the smooth muscle gap junctions will allow exchange of ions, and therefore get you past the threshold and then give you an action potential and contraction. All right, but these cells of Cargill, interstitial cells, these pacemaker cells in the myenteric plexus, they're going to have calcium channels open in them to cause depolarization, and then have repolarization by opening up potassium channels, and then they repeat this they cause these channels to open on the smooth muscle cells until action potentials are triggered. All right, but generally the maximum rate, as we said, of contraction of any particular part of the GI tract is set by the slow wave from these interstitial cells of Cargill. So the stomach is 3 slow waves per minute, duodenum is 12 slow waves per minute. All right, and then here's just another image, myenteric plexus. We have our circular muscle, we have our longitudinal muscle. We can see that's in between, and these pacemaker cells are innervating our smooth and longitudinal muscles. All right, so then really the next main concept was, now that we have some of the basics, right, we have kind of a pacemaker set up from these, the myenteric plexus, part of the enteric nervous system of the GI tract, is going to help with motility, contraction of the muscle, to help move boluses. Basically, what's going on with motility for each of the individual sections. So we have the mouth, then we have the throat, aka the pharynx, then we have the esophagus, then it goes into the stomach, small intestines, large intestines, rectum, anus. So how is motility in each of these different sections being affected? So starting with the first three, which is mouth, throat, pharynx, and esophagus, chewing and swallowing is going to occur there. So starting with chewing, of course, we have the mouth to break up and lubricate the food. Swallowing is voluntary in the mouth, but involuntary once you get past the mouth, and it's controlled by the medulla's swallowing center. So sensory information is sent to the medulla via the vagus nerve, which is cranial nerve 10, and the glossopharyngeal nerve, cranial nerve 9. And then basically output motor control is sent to the pharynx and the upper esophagus once you get past the back of the mouth. So the 3 phases of swallowing, you have the mouth/oral phase. The tongue forces the bolus, aka round mass of food, to the pharynx, which sets off somatosensory receptors, and then these will go up again to the medulla via the vagus nerve and glossopharyngeal nerve. Then once you're past the mouth into the pharynx, you have the pharyngeal phase, which is pharynx to esophagus, and in that phase, the soft palate is pulled upwards, so this part right here, the soft palate is pulled upwards to keep food from going into the nasopharynx, which is here, so it's pulled upwards to block that. And then you have the epiglottis, which I don't know if we have a good picture of. Epiglottis right here to cover the trachea. And so the epiglottis and the larynx are going to move, or I said trachea, I meant larynx. Epiglottis is going to cover the larynx, which we know is above the trachea. And then we have the upper esophageal sphincter, which is right here. is going to relax such that food can get into the esophagus, and then you have this peristaltic wave of contraction as we have motor innervation coming from the medulla after these somatosensory receptors have been set off as the food first moves into the pharynx. All right, and so this peristaltic wave is going to help get the food the rest of the way. We also have gravity helping us, but the idea is that we have this upper esophageal sphincter relaxing right here, and when you have the food finally get into the esophagus, which is phase 3, esophageal phase, you're going to have the swallow reflex close the esophageal sphincter after the food gets in, and then you're going to have a continued peristaltic wave traveling down the esophagus. And so this is going to be set off by the swallow reflex. Basically, you have these somatosensory neurons that's going to activate the plexi in around the smooth muscle, and that's going to help with peristalsis, so this contraction behind the bolus. And so you have the combination of gravity pulling the bolus down, and then you have contraction behind the bolus, and then you also have relaxation in front of the bolus. And then you also have this idea that the pressure inside the esophagus itself, right? We have a seal up here, the sphincter here, and we have a seal in the lower esophageal sphincter. The pressure here is supposed to be at equilibrium with the pressure in the thoracic cavity, so it's less than atmosphere. And so you have the force of gravity pulling downwards, you have this peristaltic contraction behind the bolus, and then you also have a lower pressure inside of the esophagus than further up. And so all these things are helping pull the bolus of food to the stomach. All right, and so then finally the food goes through the lower esophageal sphincter into the stomach. The sphincter there relaxes. I don't know if I have a good picture of it. Oh yeah, so right here, the sphincter relaxes, and you have these basically the sphincter, lower esophageal sphincter has a baseline tonal stimulation keeping it closed generally, but nitric oxide and then this neurotransmitter VIP is released by the enteric nervous system for nitric oxide and the VIP by the vagus nerve to inhibit contraction and cause dilation of this sphincter at the lower esophageal sphincter. So that will open up the sphincter, cause it to relax, allow food to pass through, and then you also have the ORAD region of the stomach relax in preparation for the food to arrive. All right, so that brings us to the fourth part of motility. We have the gastric stomach motility. So what's affecting this? Before we get into that, we have to talk about quickly sort of the breakdown of the stomach, the gastric region. So we have three muscular layers. We have deepest, we have the oblique layer, then we have the circular muscle, and then the longitudinal muscle. We have three main divisions. We have the fundus, the body, and then the antrum. And we have basically two functional divisions, which is the ORAD region and then the caudad region. The ORAD region is going to have a couple of different motility influences. In particular, it has the oxyintic, aka fundus gastric glands, and this is the region that's going to receive the ingested meal. As we set up here, you have the lower esophageal sphincter get relaxed through stimulation from the enteric nervous system and releasing nitric oxide, and then the vagus nerve releasing VIP, and so that was affecting the lower esophageal sphincter. But you can see that that's adjacent with the ORAD region, so the ORAD region is also going to be affected, and it's going to relax as the vagus nerve stimulates this region as food approaches. And so helping this relaxation, you also have a couple of other things. So stretch receptors are going to stimulate this vagal reflex, which is release VIP to relax this region, prepare for food, and then you also have CCK hormone, which is released by the small intestine, and that's going to increase the ability for the ORAD region to relax, distend. All right. You do not have a quote-unquote slow wave here from the myenteric plexus, those caudal cells, but you do have tonic contractions, which be gentle contractions to push food into the distal stomach, the antrum, caudad region. All right, so then the caudad region right here, we have a couple of motility influences as well. In particular, we're back to our peristalsis, so peristaltic contractions with our friend the slow wave. The purpose here is to mix food with gastric secretions and begin digestion. And so you have these slow waves, which are setting the rhythm, max rate of 3 to 5 waves per minute. It's going to help depolarize the layers of muscle in the stomach, oblique, circular, longitudinal. And basically, it's actually going to cause the caudate end to close. So this end right here is going to cause it to close, and it's going to push the food back to the stomach for mixing. And then you have the ORAD region, which is gently going to push the food this way. And so you have a mixing of the food overall. But the net result is, eventually you're going to have food leave through the pyloric sphincter into the duodenum. All right, you also have another influence on the caudad region. You have this idea of the migrating motor complex. And so this is specifically in the case of fasting or not eating. You'll have a slow wave of contraction from the stomach to the rectum that occurs every 90 minutes or so. And we call this the migrating motor cortex. And it's mediated by this hormone motilin. But basically, again, during fasting or not eating, it's a housekeeping function to clear residual contents. All right, so then these are the motility influences on the two regions of the stomach. But if we're talking about emptying the stomach overall, it turns out that the physical contents of the physical characteristics of the contents matter. Lipids are going to empty faster than solids. Intuitively, that would make sense. Just easier for liquids to flow. Solids have to be reduced to a small particle size before they can move on to the duodenum. Contents that are isotonic to the fluids in the stomach are going to empty faster. Hypotonic contents are slower, and then hypertonic contents and hypotonic contents empty slower. And then fats are going to inhibit gastric emptying by stimulating CCK release from the small intestine, which we already said relaxes the stomach. And so it's going to make it harder for food to leave, which is interesting because that tells us why eating fats will keep you full for longer. All right, and then we also have an increase in the acidity of the duodenum. It is going to inhibit emptying of the stomach via a direct neural reflex, which is going to cause secretin hormone to be released. Secretin is going to reduce stomach peristalsis, so reduce stomach contraction to maintain the pH in the duodenum. So basically it says if the duodenum is too acidic, it could cause damage. So slow down, don't push as much stomach acid and the chyme from the stomach into the duodenum to slow down. So secretin is going to do that. It has a number of other effects, but so far we've only really learned about the fact that it's trying to regulate the pH in the duodenum, and it's going to reduce peristalsis in the stomach. All right, so that after we leave the end of the stomach, we go through the pyloric valve into the duodenum, and we get into the small intestines. And so the small intestines are the major site of digestion and absorption. We're going to have the mixing of nutrients with more digestive enzymes. We started this in the stomach. Again, we're back to our enteric nervous system doing our slow waves that are going to set our basic rhythm. It's faster than in the stomach at 12 waves per minute. The parasympathetic nervous system will stimulate, get us closer to this 12 waves per minute, and then our sympathetic nervous system will inhibit this overall, right? Rest and digest, fight or flight. Our contractions within the small intestines can be classified as segmental or mixing, and so you can see this. It's basically a contraction of smooth muscle in the middle of the bolus, round bowl of food, and that's going to push it, split it, and then relaxing will bring the food back. And so the idea is that you mix it, you break things up, and mix the nutrients with the digestive enzymes, and then you also have contractions that are friend peristaltic, which are like our move along contractions coordinated by our enteric nervous system with our friend our slow waves, where segmental is more the mechanoreceptors. All right, so more with our peristaltic move along. You do have the influence of sensing by the enterochromaffin cells, which are lining the walls of the small intestines. They're going to release its substance called 5-HT, 5-hydroxytryptamine, which binds to intrinsic primary afferent neurons, which are going to get us past the threshold that we get close to with our slow waves. And then as a result, we are going to have a contraction behind the bolus due to excitatory neurotransmitters causing circular muscle contraction, and then in front of the bolus we have inhibitory neurotransmitters causing relaxation, and then excitatory neurotransmitters are going to cause longitudinal smooth muscle contraction, which we said shortens but also increases diameter. All right, so the combination of these things is going to help the bolus move. And then final thing to mention, we have this idea, gastroileal reflex, controlled by the autonomic nervous system and the gastrin hormone. Basically, food in the stomach is going to trigger increased peristalsis in the ileum, and it's going to relax the ileum cecum sphincter. So if you have food in the stomach, it's going to increase peristalsis movement at the end of the small intestines, so kind of start making way for more things to come in. All right, so we're almost done with this section. We have the large intestine motility. Large intestine is going to absorb water and electrolytes, store feces until it's expelled. So we've left the small intestine. Now we're dealing with the cecum, ascending colon, transverse colon, descending colon, sigmoidal colon, and then our friend the rectum, and our anus. Maybe not the friend. Wrong word. Okay. Anyways, we have the cecum right here, and the proximal colon. So the ileum cecum sphincter right here is going to contract to prevent feces going back into the ileum. You have two types of movements in this region. In the colon, segmental contraction of these segments. And it's responsible for the appearance of these segments overall, called haustra. And then the main movement that we have, this segmental is going to really mix the contents, that's the purpose. And then you have mass movements, which are propelling the feces overall through the colon, and it happens 1 to 3 times a day, and the colon contents move distally for long distances. All right, and then the distal colon, mostly water absorption has already occurred in the proximal colon. Feces are semi-solid and move slowly, and then mass movements are going to propel the feces to the rectum. All right, which brings us to our rectum and anus. So here's the rectum, here's the anus, and feces are moved into the rectum from the sigmoidal colon. At 25% of fill, you feel the need to poop, and then we have the internal anal sphincter right here, which will relax through reflex once you get to this 25%, but the external anal sphincter stays contracted, and this will stay contracted until you voluntarily decide to poop. All right, and then we have this gastrocolic reflex. When food is in the stomach, it's going to increase the motility of the stomach and frequency of mass movements, and this is due to parasympathetic stimulation after the stomach is stretched. And again, similar to the gastroileal reflex, you're making movement so that the stuff coming in can take its place. All right, disorders of the GI tract, irritable bowel syndrome, constipation, diarrhea, and then Hirschsprung disease, where nerves of the large intestine are missing. All right, then the final concept from this lecture was vomiting, which is due to reflex controlled by medulla, receives input from the GI tract, labyrinth receptors in the ear, gag reflex receptors in the throat, GAG receptors in the throat, pain receptors, and then chemoreceptors on the medulla itself for circulating chemicals such as apomorphine. The steps in basically this vomiting reflex is diffuse sympathetic nervous system response, causing tachycardia, tachypnea, breathing too much, sweating, decrease in GI motility, parasympathetic relaxing of the sphincter or esophageal sphincters, increase in salivation, and then a transient temporary increase in GI motility, as well as a reverse of peristalsis, so things moving in the opposite direction, which is strange. Deep breathe in, and then the anterior abdominal muscles are going to contract, contents from the stomach go up the esophagus. If they don't exit the esophagus completely, you'll get a secondary peristalsis in the esophagus, which will pull the contents back to the stomach. The effects of vomiting, dehydration, hypokalemia, aka lack of decrease in potassium, and then alkalosis, you're becoming basic due to the loss of acid, HCl. All right, so just quickly, I wanted to mention, so we had the, let's see, in the esophageal phase of swallowing, we had the peristaltic wave down the esophagus. You have the swallow reflex, and then if your food doesn't make it all the way down, you have a second wave needed from the enteric nervous system. That was the second wave described here, secondary peristalsis. All right, the clinical correlations, you can read these yourself. I don't want to go over them. We're going to take a short break right now before moving on to the next lecture. All right, we're back. So this is the next lecture, lecture 42, regulation of the alimentary canal, aka GI tract. So we're going to be looking at saliva production, what are the different hormones involved, and then hunger, secretions of HCl, and then looking at some ulcers, but really a lot on stomach acid. All right, so starting off with the top of the Well, in the mouth region, we have the regulation of saliva production. And so you think to yourself, rest and digest, you're just like, well, it must be just the parasympathetic nervous system. Actually, the saliva production is under the control of both parasympathetic and sympathetic nervous system, and they both will stimulate the production of saliva from acinar or ductal cells within the mouth. And so basically, parasympathetic or sympathetic will stimulate. Parasympathetic generally gives you the watery saliva. Sympathetic will give you kind of a more thicker saliva during fight or flight, but the stimulation will cause an increase in saliva production, an increase in bicarbonate production, increase in enzyme secretion, and then an increased contraction of myoepithelial cells. And again, you just have binding of receptors from so neuroepinephrine to beta receptor in the case of sympathetic nervous system. Parasympathetic, you do have some feedback such as food, nausea, smell, dehydration, fear, sleep are going to decrease sympathetic stimulation. And then you have cranial nerve 7 and 9, the facial nerve and glossopharyngeal nerve, respectively, releasing acetylcholine onto our muscarinic receptors, and the net result is stimulating the production of saliva. Importantly, though, our friend atropine will block this effect and decrease saliva production. All right, so then in terms of the compounds secreted by the GI system that are going to do regulation, beyond just simple innervation, we have a bunch of different hormones, and so in particular we have hormones. Four main ones, then we have our paracrines, and then our neurocrines, but the four main GI hormones are, so starting with hormones and not paracrines or neurocrines, paracrines released by endocrine cells, hormones released by endocrine cells, but neurocrines released by neurons in the GI tract. GI hormones, the big four are gastrin, CCK, which is from our small intestines, secretin, and then GIP, glucose-dependent insulotropic peptide. All right, so starting with our friend gastrin, gastrin is going to be released by G cells of the stomach. It increases H plus secretion, so hydrogen ion secretion, and stimulates the growth of gastric mucosa. Why would that be good? Well, protect the walls of the stomach from the increase in acid that gastrin is stimulating. So from G cells of the stomach, stimuli for secretion is small peptides specifically, or amino acids specifically, that will really cause this, or to great effect, phenylalanine and then tryptophan, distension of the stomach from the ingestion of food, and then vagal stimulation, in particular GRP, which is gastrin releasing peptide, will cause more gastrin to be released, which will then cause the effects of gastrin, increase in H plus from our parietal cells. All right, then there is negative feedback inhibiting the release of gastrin. Basically, if you have a high concentration of hydrogen ions, the stomach can be very acidic, and then you have somatostatin is going to inhibit the release of gastrin. We'll talk about somatostatin in a little bit, but it's the master inhibitor. All right, so that's gastrin, increase HCl production, stimulate growth of the gastric mucosa. Then we have CCK, cholecytokinin. It's released by the small intestines, the eye cells, the duodenum, and the jejunum. Very similar to gastrin, right? We have a hormone family of gastrin, CCK, and so the stimuli are going to be similar. Small peptides, amino acids, fatty acids, and then monoglycerides are going to stimulate the release of CCK from the duodenum and the jejunum. But basically what this is going to do is increase pancreatic enzyme secretion to increase digestion, increase bicarbonate secretion, stimulate contraction of the gallbladder and relaxation of the sphincter of Oddi, stimulate the growth of the exocrine pancreas and gallbladder, and then inhibit gastric emptying. So keep the contents of the stomach. We said that this guy will help relax the ORAD region of the stomach, the first part of the stomach. All right, so then we said fatty acids earlier. Fat in the small intestines would stimulate the release of CCK and inhibit gastric emptying by relaxing the stomach. All right, then we have secretin. And secretin is all about decreasing the acidity of the duodenum to keep our ulcers from forming. This is going to increase pancreatic bicarbonate secretion. Right? Bicarbonate is basic, so it would neutralize acid in the duodenum. And then biliary bicarbonate secretion, increase that, decrease gastric hydrogen ion secretion, then inhibit the trophic effect of gastrin on gastric mucosa. So basically keep the gastric mucosa from growing. And then stimuli for secretion is basically acid in the duodenum or fatty acids in the duodenum. All right, and then this is from the S cells in the duodenum, secretin S cells. Then we have GIP, glucose-dependent insulotropic peptide, GIP, and this is going to increase insulin secretion from pancreatic B cells and decrease gastric hydrogen ion secretion. It's released from the duodenum and jejunum, and I'll have more information on that. And this is going to be stimulated in response to fatty acids, amino acids, or glucose in the mouth. All right, so we have gone over our four basic hormones. Now we have our paracrines and our neurocrines. Paracrines also coming from endocrine cells. And the neurocrines are coming from neurons. Our paracrines, endocrine cells of the GI tract, they're going short distances, whereas these guys are going further. Paracrines, you have somatostatin, which is our main one. Basically, it is our master inhibitor. It inhibits the release of all GI hormones. All right, so all gastrin, CCK, secretin, GIP, and it is importantly going to inhibit the gastric hydrogen ion secretion, so help lower the acidity. It's secreted if the hydrogen ion concentration in the GI lumen is acidic, so basically somatostatin. If your GI tract is acidic, you're going to release somatostatin. All right, and then you have histamine. Histamine, we know, is pro-inflammatory. It's secreted by mast cells of the gastric mucosa, and it's going to increase gastric hydrogen ion concentration via two mechanisms, directly stimulating it, and then potentiating or increasing the effects of gastrin and vagal stimulation of the parietal cells. All right, then we have our neurocrines. So neurocrines are synthesized and released by the neurons of the GI tract. They include VIP, which is, we've already seen, it's relaxing the lower esophageal sphincter. It's vasoactive intestinal peptide. The action is produces relaxation of GI smooth muscle, including the lower esophageal sphincter. It's similar to secretin. It stimulates bicarbonate ion secretion and then inhibits hydrogen ion secretion. So basically make things less acidic. VIP will do that. All right, and then GRP, which we already saw, gastrin releasing peptide up here. is going to be released by the vagus nerve and it innervates G cells, which we know release gastrin, and it is going to stimulate gastrin release from G cells. And then you have the enkephalins, such as met-enkephalin and lev-enkephalin. They're released by the nerves of mucose/smooth muscle of the GI tract. It's going to stimulate contraction of the GI smooth muscle, particularly in the lower esophageal, pyloric, and ileocecal sphincters. It inhibits intestinal secretion of fluid and electrolytes and forms the basis of the usefulness of opiates in diarrhea treatment. So similar to opioids in structure, and it will inhibit intestinal secretion of fluid, which is what happens in diarrhea. All right, so then regulation of satiety, you know how full you are. You have two hypothalamic centers, which control satiety and hunger. You have the satiety center, which inhibits appetite and then makes you feel more satious, I suppose. And then you have the feeding center, which stimulates appetite. You have anorexigenic neurons, which release pro-opiomelanocortin, POMC, which decreases appetite. And then you have the orexigenic neurons, which release neuropeptide Y, which stimulates appetite. So neuropeptide Y stimulates appetite, and then POMC decreases appetite, and it comes from our anorexigenic neurons. All right, that one's easy to remember. Anorexia, you are super thin, not eating, and anorexigenic neurons release POMC, which decreases appetite. All right, then you also have leptin, which is secreted by fat cells. It stimulates the anorexigenic neurons and inhibits the orexigenic neurons, thus decreasing appetite. So leptin decreases appetite, and then ghrelin increases appetite by stimulating the orexigenic neurons and inhibiting the anorexigenic neurons. So ghrelin makes you hungry, leptin makes you feel full. All right, or decreases appetite. Then you have the secretions from the stomach itself. So we've already kind of talked about this, but we have our different parts of the stomach. We have the body of the stomach, and then we have the antrum. And so we have the body of the stomach has oxyentic glands, or aka fundic or gastric glands. And just going from top to bottom, we have our epithelial cells, our mucous neck cells, our parietal cells, and then our chief cells. Importantly, the parietal cells are going to release HCl and intrinsic factor, which is important for digestion of fats. HCl, just important in general for breakdown of activation of pepsinogen to peptin, particularly for protein digestion. But we also know that acid can help kill things that aren't supposed to be in the stomach. Then you have the antrum region has pyloric glands, which are like the gastric glands, but have only two cell types. They have G cells, and then they have mucus cells, and we know G cells secrete gastrin into the blood circulation, which then eventually comes back and affects our parietal cells. Our mucus cells are going to secrete mucus, bicarbonate, which is basic, and then pepsinogen as well. Of course, we know most of the pepsinogen is coming from our chief cells in the oxyentic glands from the body of the stomach. All right, so then if stomach acid is so important because it's going to be converting, the goal of secreting hydrogen ion is going to act as an acid. So secrete hydrogen ion, form hydrochloric acid, HCl, to convert pepsinogen to pepsin for protein digestion. And so basically here we have our gastric parietal cell, which we said is going to release HCl and intrinsic factor. But importantly for HCl here, we start off with our friend's carbon dioxide from our blood, and we know that carbon dioxide will be reacted with water by our friend carbonic anhydrase, and that will eventually be broken down to hydrogen ion and bicarbonate ion. At the apical surface right here, we have the hydrogen ion is secreted into the lumen via hydrogen ion potassium ATPase, which is this guy. You can see that potassium ion is coming in from the lumen of the stomach, and then hydrogen ion is going out. Then you also have chlorine ion at the apical surface is going to diffuse out of the cell into the lumen of the stomach, and then you have H plus out here, and then you have Cl minus out here, and then they will make our friend HCl. All right, and then at the basal membrane, you have the bicarbonate ion from our carbonic anhydrase reaction is going to go into the blood, and specifically you have this bicarbonate chlorine exchanger, which is going to bring chlorine into the cell, which we know at the apical surface is going to go through a chlorine channel into the lumen. All right, so bicarbonate chlorine exchanger. And basically, when you have a lot of food eaten, you have an increase in HCl production, and the result is you have bicarbonate ion pumped out into the blood. or chlorine comes into the cell, but this bicarbonate, is basic, and so you have this alkaline, aka basic tide after meal due to this bicarbonate secretion. All right, so we have H plus going out based on H plus K plus ATPase, and then you have Cl minus going through Cl channels. How can we affect H plus secretion? We've already kind of talked about this, but let's just specify a little bit more. We have histamine, which will increase hydrogen ion secretion. Acetylcholine from our vagus nerve will act on parietal cells, increase hydrogen ion secretion. And then gastrin, we know, is from our G cells. It goes to the blood, to our parietal cells. It binds to CCK receptors on parietal cells. It's going to increase secretion. And then we know that G cells get stimulated to release gastrin by the presence of small peptides. We said tryptophan, and we said phenylalanine. All right, and then we said distension of the stomach will also stimulate gastrin to be released. Okay, histamine, we know, is pro-inflammatory. It's released by the enterochromaffin-like cells, ECL, in the gastric mucosa. It binds the parietal cells and stimulates H plus secretion. And then the drug cimetidine is going to block H2 receptors and will therefore block histamine's effect. Okay, and then we know acetylcholine from the vagus nerve acting on M3 receptors in parietal cells increases H plus stimulation. So friend atropine is going to block this and block H plus secretion. All right, so then that brings us to phases of H plus secretion. Basically, we have stimuli based on where food is. So you have phase one, the cephalic, aka head region, or head phase. This accounts for 30% of hydrochloric acid release in response to a meal. The stimuli are smelling, tasting, chewing, and swallowing. The mechanism behind this is direct stimulation of parietal cells via the vagus nerve from acetylcholine, and then indirect stimulation by the release of gastrin. Basically, the vagus nerve is going to stimulate G cells through the release of the neurotransmitter GRP, which we know is the gastrin releasing peptide that the vagus nerve can release on our G cells. All right, and so then we have phase two, which is the gastric, aka stomach phase. This is 60% of HCl released in response to a meal due to stomach distension, which we know affects our G cells, and then our amino acid small peptides, which affect our G cells. So distension, vagus nerve is going to stimulate our parietal cells, also stimulate gastrin release, and then finally we have phase three, the intestinal phase. That's 10% of HCl secretion, and the stimuli is going to be a need for protein digestion. We know again that the purpose of our HCl secretion is partially to activate pepsinogen into pepsin. Okay, so this whole stuff is just saying what we already said, cephalic phase, head phase, and the stomach phase, and then what are the stimuli, distension, and then we have the effects of our vagus nerve on both our parietal cells and our G cells overall. All right, and then second last thing, inhibition of stomach acid secretion via negative feedback. Basically, if you have a very acidic stomach, this is going to result in decrease in hydrogen ion secretion by reducing gastrin secretion. Basically, somatostatin, the master inhibitor, will decrease the secretion in two ways: directly by binding to parietal cells. Somatostatin will bind and inhibit adenylyl cyclase, which is going to counteract the effects of histamine, which has stimulatory effects. So net result is decrease the release of HCl from parietal cells. And then our indirect mechanism is somatostatin is going to inhibit histamine and gastrin release from ECL cells and then G cells respectively. And then finally you have prostaglandins, which are going to antagonize histamine stimulatory effects and therefore reduce HCl secretion. Okay, finally we have our ulcers, which are not fun. We can see our ulcers right here. We see that the mucosa of the stomach has been eaten through. Yikes. So what are ulcers? Lesions of the stomach or duodenal mucosa, or peptidic ulcers are, and they're caused by the erosive and digestive effect of H+ and pepsin. Right, pepsin only works on proteins, but what is our stomach all made up of? Muscle, full of protein, on mucosa. And basically, for this to occur, for you to have these lesions, you have either the loss of the protective mucus barrier, which we know has mucus and then bicarbonate in it, and then excessive hydrogen ion secretion and pepsin secretion, or the combination of loss of protection and excessive secretion of HCl and pepsin. The protective layer is a gel-like mucus layer from our mucous neck glands, okay, from our fundic, aka oxy-intake glands in the body of the stomach, and then we have bicarbonate from our gastric epithelial cells trapped in the mucus, and that neutralizes the HCl and pepsin. Right, remember pepsin is activated by HCl from pepsinogen. Okay, so it's just a reminder of what our glands look like: epithelial cells at the top, mucus cells producing our mucus, and epithelial cells giving us our bicarbonate. And here's just an example of what this looks like. We see our mucus, we have our protective bicarbonate, which is basic, and below that we have our mucosal cells. Damaging factors are H. pylori infection is huge, and then non-steroidal anti-inflammatory drugs such as aspirin or ibuprofen can damage the protective barrier. Stress, smoking, and alcohol can make it worse. You know, alcohol is absorbed partially through the wall of the stomach. And then we have classification of these ulcers. You have duodenal ulcers, that are the most common. Basically, an excess of acid is going to overwhelm the buffering of the duodenal region of the small intestines, and that bicarbonate buffer is coming from Brunner's gland in the duodenum. We haven't really seen too much on that in lecture, just as mentioned. And then we have the gastric ulcers. Generally, you have a poor mucus layer, or you have an infection from the gram-negative bacteria H. pylori, which infection of that will inhibit somatostatin release and therefore cause less HCl secretion inhibition. Okay, and then these are just some symptoms: stomach pain, hiccups, burning feeling, black tarry stools, bloating, loss of appetite, nausea, vomiting, blood, or coffee, ground-like material, and indigestion. Not good. We do have some clinical correlations for this. I encourage you to take a look at them. We're going to take a pause here, and we'll be back in a few minutes. All right, we're back with our final lecture, lecture 43. Summary: we have digestion and absorption. So pretty much we're just looking at the basics of digestion and absorption with a focus on what we're actually doing that on: carbohydrates, proteins, lipids, and getting in some vitamins, calcium, and iron, and then talking a little bit about fluid and ending with a discussion of diarrhea. So starting with our basics of the GI tract, we have digestion is the chemical breakdown of food using enzymes in the salivary, gastric, and pancreatic juices, and then these enzymes are also on the apical surface of intestinal epithelial cells. Absorption refers to movement of nutrients, water, and electrolytes from the lumen of the GI tract into the blood. There's generally two ways that this can be accomplished. One is cellular or transcellular, same thing. Basically having the substance move across the luminal membrane, apical luminal membrane, because the lumen's right here, into the cell, and then through the basolateral membrane into the blood. The other way is the paracellular pathway, which is through the tight junctions in between the epithelial cells. All right, so then what are the structural features that are helping with digestion and absorption in the GI tract? Well, we have, of course, our villi coming off of the walls of our intestines, and then off of these villi projections, which you can see coming off of these circular folds, aka the folds of Kirkering. We have our villi coming up, and then if you look at the cells individually, they have epithelial cells are going to have microvilli, and so the net result is with these villi coming up and the microvilli coming off, an increase in surface area, and then the surface of the small intestine has these folds of Kirkering to extend the surface area even more. And so the length of these villi is going to decrease from the duodenum to the end of the ileum, aka the end of the small intestine, and the villi are lined with the enterocytes, those epithelial cells, and then goblet cells for the secretion of mucus, again, protect us from acid. All right, then we have the apical surface of the microvilli of the enterocytes have the brush border microvilli to increase surface area, as we already said. So that's the basic, at least in terms of structures. And then starting with our carbs, we love carbs. Basics: ingested carbs are polysaccharides, meaning many monosaccharides together, or disaccharides, two saccharides together are polysaccharides and disaccharides. We have sucrose, lactose, maltose, and trehalose are two monosaccharides, or glucose and fructose. Only monosaccharides are absorbed by intestinal epithelial cells, so we need to break down our polysaccharides into monosaccharides. And so this breakdown starts with salivary alpha amylase, which starts to break down polysaccharides in the mouth, and then pancreatic amylase breaks down 1,4-alpha glycosidic bonds and helps break our polysaccharides down to disaccharides. And you have basically alpha-limit dextrin, maltose, and maltotriose will get broken down into by alpha dextrinase, maltase, and sucrase, and that has the help of intestinal brush border enzymes. The three disaccharides in food, we have trehalose, lactose, sucrose, and they get digested by trehalase, lactase, and sucrase. And we can see that here a little bit with glucose. So we have our starches or polypeptides broken down by alpha amylase from our saliva into alpha dextrins, maltose, and maltotriose, and then those get broken down by sucrase for maltotriose, maltase for maltose, and alpha dextrinase, and they all get broken down into glucose, Halose gets broken down into glucose, and then lactose into glucose and galactose, and then sucrose into glucose and fructose. But specifically, you have salivatory amylase and then the pancreatic amylases in the small intestines. Okay, so the mouth and then the small intestines. Okay, once you have broken down into our monosaccharides, glucose, galactose, fructose, then you can start to do absorption. So glucose and galactose are absorbed across the cell membrane by secondary active transport, which you can see here. All right, secondary active transport with our friend sodium ions helping down the sodium ion gradient, glucose and galactose. And then they're excreted by the GLUT2 transporter into the blood. All right, fructose crosses via GLUT5 into the epithelial cells of the small intestines, and then leaves via GLUT2 into the blood. Okay, so that is for carbohydrates. Then we have proteins. Breakdown of proteins begins in the stomach with pepsin. We know pepsinogen gets converted into pepsin by acid in the stomach. And so the stomach will start to break down proteins, but then the rest of the breakdown into individual amino acids or proteins that are 2 or 3 amino acids long. The rest of that breakdown into the small units is completed by pancreatic and brush border proteases. So basically, proteases on the brush border microvilli or in the just lumen of the small intestine. So we do have two classes of proteases. We have endopeptidase, which is going to break down our interior bonds, and includes pepsin, trypsin, chymotrypsin, and elastase, breaking those interior bonds. And then we have exopeptidase, which is they're going to break one amino acid at a time, starting at the end, and then it just keeps getting shorter and shorter, so the end keeps getting chopped off, and it goes from C to N terminus. And we have carboxypeptidase A and then carboxypeptidase B. But importantly, all of these peptidases, or proteases, are starting as precursors, and they're generally getting activated. So we have pepsinogen going to peptin in the stomach by low pH, converting that, and then trypsogen is the most important one. It's going to be converted into trypsin, and again, this is a endopeptidase by enterokinase on the microvilli of the brush border. Once you have trypsin, trypsin is going to go and convert more trypsinogen into trypsin. It'll also convert each of the other types of protease into their final forms. So we have chymotrypsinogen into chymotrypsin, we have prolastase into elastase, we have procarboxypeptidase A into just carboxypeptidase, and procarboxypeptidase B into just carboxypeptidase. Okay, so after they do their thing, they will eventually break each other down, as we know that enzymes are generally proteins. Okay, so basically this is just what we've seen. Proteins, pepsin, will break down amino acids, and then longer peptide, slightly shorter peptides, but maybe not completely done. And then once we get into small intestines, we have our endopeptidases, which are going on the inside, trypsin, chymotrypsin, and elastase, and then we have our exopeptidases, which are acting on the outside, the exo, carboxypeptidase A, carboxypeptidase B, and we're getting down to dipeptides, tripeptides, and individual amino acids overall. Okay, so then we have our absorption of the proteins. Now that we're down to amino acids, dipeptides, and tripeptides, they're going to get absorbed by intestinal epithelial cells. The amino acids in the body are almost entirely L amino acids instead of R amino acids. Do you remember that from organic chemistry? In terms of actually getting to the cell, they're using the sodium ion gradient. So in particular, using sodium co-transporters across the apical top surface of the membrane from the lumen into the cell. And you have different types of these based on what kind of amino acid you have. So is it neutral, acidic, basic, or imino, which is really just proline? And then you also have facilitated diffusion across the basement membrane for the dipeptides and tripeptides. So just take a quick look at that. So amino acids with some form of facilitated diffusion using a sodium co-transporter, which we can see here. And then for you have facilitated diffusion for dipeptides and tripeptides into the small intestines. They can get broken down even further there into amino acids, or just exit the cell through some facilitated diffusion overall. Okay, so that brings us to lipids. We have dietary lipids will include triglycerides, cholesterol, and phospholipids. Digestion of lipids begins in the stomach, which is going to mix the lipids to break them down into droplets. In the stomach, you have lingual and gastric lipase, which is going to hydrolyze lipids down to glycerol and fatty acids, or at least do as much as possible. The slow process of mixing chyme in the stomach is intentionally slow to give the enzymes time to digest the lipids. And we, of course, know that when lipids get to the small intestines, they're going to stimulate the release of CCK, which is going to slow the rate of gastric emptying such that you can have this mixing of the chyme in the stomach and give more time for the enzymes to dissolve or to digest the lipids. Okay, and then once they finally get into the small intestines, you have bile salts, which are released by the gallbladder, secreted into lumen, and where they work in conjunction with lysylcythine, which will surround and emulsify the dietary lipids. And so you can see that here you have a lipid droplet, you have our bile salts, and they're forming these micelles right here. So the droplets get broken up into small bits and surrounded by our bile salts. All right, so then now we're in our micelles, we have our pancreatic enzymes, and they're going to work on breaking up the tiny lipid droplets. So you have a number of different ones. These are the 4 main ones, and there's really 3 main ones where colipase is helping one of them. But we have pancreatic lipase, which is going to break triglycerides down to monoglycerides and fatty acids. Then you have cholesterol ester hydrolase, which is going to break cholesterol esters into cholesterol plus fatty acids. Then you have phospholipase A2, which is going to be activated by trypsin, and it breaks down phospholipids into lysylcythine and fatty acid. And then our pancreatic lipase unfortunately gets inactivated by these bile salts, but colipase, which is released as prolipase, which is activated by trypsin, and trypsin we know is kind of the default activator of things, which we saw with our proteases. Trypsin is going to convert prolipase into procolipase into colipase. Colipase is going to bind to pancreatic lipase and keep it from getting inactivated by the bile salts. Okay, so we have breakdown of our triglycerides, cholesterol, phospholipids into monoglycerides, fatty acids, cholesterol, lysylcythine, and glycerol. They have been surrounded by bile salts to form our micelles. Now that we have micelles, which have these things inside of them, they are going to, with the exception of glycerol, because glycerol is water soluble, things that aren't water soluble, all of these guys, except for this one, are going to diffuse, come adjacent to the plasma membrane, and then the insides, all of these guys are going to go into the cell. These products inside the cell are going to be re-esterified to form the original ingested lipids, aka the triglycerides, cholesterol esters, and phospholipids, and then these re-esterified lipids are going to be packaged with apoproteins into lipid-carrying particles called chylomicrons. So these chylomicrons are going to form inside of the cell. It's going to be a lot of phospholipids and then these apoproteins, mostly phospholipid, 80% phospholipid, 20% of the surface is going to be apoproteins, and inside is going to be re-esterified products. cells. Once you have these chylomicrons, they're going to be packaged into secretory vesicles by the Golgi. It's going to leave the cells, but instead of going directly to the blood, it's going to go into the lymphatic circulatory system, aka the lacteals, and then travel to the thoracic duct, which we know is in the posterior part of the thorax and abdomen along the spinal cord, and then it's going to go into the blood from there, where then it will get absorbed by individual cells. All right, so that was quite a lot, but we have our micelles, and then we have our chylomicrons, which eventually will leave and go into the lymph overall, and then to the blood. All right, so then we have vitamins, and we remember we have water-soluble vitamins and fat-soluble vitamins. Fat-soluble vitamins go through the exact same absorption process as lipids, so our micelles, our chylomicrons. Water-soluble, which are B proteins, B1, 2, 3, 5, 6, 7, 9, and 12, and then vitamin C. All except for B are going to do basically the same thing that proteins or amino acids go through, which is use a sodium co-transporter. So you can remember they're water-soluble, so it's going to do the same thing sodium does, or proteins do, which are also charged, and use a sodium co-transporter to get into the small intestines. Vitamin B12 is the exception, and this is going to require intrinsic factor, and so B12 cobalamin requires intrinsic factor. B12 is released from foods by digestive action of pepsin in the stomach. B12 binds to R proteins secreted in salivary juices in the duodenum. The pancreatic proteases degrade the R proteins, causing B12 to transfer and bind to intrinsic factors, which is secreted by parietal cells in the stomach. The vitamin B12 and intrinsic factor complex travels to the ileum, where it gets absorbed via a specific transport mechanism, which we haven't discussed past just mentioning it in the lecture. But you can see this here. B12 comes in, binds to our R protein. R protein gets broken down, and then it's going to bind to intrinsic factor, and then the combination of intrinsic factor with B protein is going to get absorbed in the ileum of the small intestines. All right, and then importantly, we have this idea gastrectomy, which is basically just like shortening or removing a giant chunk of the stomach, can result in the loss of parietal cells, which we also know produces hydrochloric acid, right? But it also produces intrinsic factor, and so if you can't have your source of intrinsic factor, then you're going to vitamin B12 deficient, and you get pernicious anemia, which is just a decrease in production of red blood cells, but it's not good. Okay, calcium and iron absorption. Calcium is absorbed in the small intestine, depends on vitamin D, the active form, which is 125 dihydroxy cholecalciferol. The intestine has a vitamin D dependent calcium binding protein called calbindin D28K. It's important for absorption. Deficiency of calcium will result in osteomalacia and rickets in adults and kids, respectively. But calcium small intestine depends on vitamin D. Iron is absorbed across the apical membrane of intestinal epithelial cells as free iron or as heme iron, iron attached to hemoglobin or myoglobin. Free iron binds to apoferrin in the cell and is transported across the basement membrane. Once it's in the blood past the basement membrane, it binds to transferrin, where it goes from the small intestine to storage in the liver, and then after the liver, it will get sent to the bone marrow for hemoglobin synthesis. All right, and then we have a discussion on intestinal fluid and electrolyte transport. So basically, approximately 8.5 liters of fluid is absorbed daily by the small and large intestines, and it's mostly from the small intestines. The epithelial cells there 6.5 liters and about 1.9 liters in the colon. The epithelial cells also absorb and secrete electrolytes, specifically sodium ion chloride, bicarbonate, and potassium. And then the routes of absorption for fluid and electrolytes, intracellular and paracellular, which we talked about forever ago, are the routes of absorption. The leaky small intestines have leaky tight junctions. Large intestines have non-leaky tight junctions and don't allow for paracellular transport. So large intestines no paracellular transport. Small intestines do. All right, the jejunum is the major site of sodium ion absorption, as you have the co-transporters, which we're already familiar with for glucose, galactose, amino acid co-transporters. We also have hydrogen ion transporter to enter the cell, and then sodium will leave the cell via sodium potassium ATPase. You also have a bicarbonate transporter on the basement membrane within the jejunum, and so you can see these here: sodium co-transporter with sugar amino acids, and then a sodium hydrogen ion exchanger, and then sodium potassium ATPase to leave the cell on the basement membrane side. In the ileum, you have the same transporters as the jejunum. Are co-transporters, sodium glucose, sodium galactose, sodium amino acid, sodium hydrogen ion exchanger, but you don't have a bicarbonate transporter on the basement membrane. Instead, you have a chlorine transporter on the basement membrane of the ileum. You also have a chlorine bicarbonate exchanger on the apical surface of the ileum. So we can see this here. Our sodium co-transporters bring things in. Our sodium hydrogen exchanger. Then we have this new one, bicarbonate chlorine exchanger on the apical surface. We do not have a bicarbonate transporter here, but we do have a chlorine transporter in the ileum. Okay, so jejunum has a bicarbonate transporter on the basement membrane. The ileum does not have that, but it has a chlorine transporter, and it also has a chlorine bicarbonate exchanger on the apical surface. All right, and then in the colon, large intestines, on the apical membrane, we have sodium channels for sodium absorption, potassium channels for potassium secretion. Aldosterone will induce sodium channel synthesis. This leads to an increase in sodium ion absorption and potassium secretion in the large intestines. An increase in sodium channels means an increase in sodium absorption and an increase in potassium pumped out of the basement membrane by the potassium sodium ATPase, and that will result in more potassium in the cell and therefore increased potassium out of the apical membrane. In diarrhea, the increase in intestinal fluid flow causes an increase in potassium secretion, results in increase in potassium feces and increase in hypocalcemia, which means not very much potassium in the blood. All right, so this is just what we were saying. You have on the apical surface, adjacent with the lumen, sodium channel, potassium channel. You have sodium potassium exchanger on the basement side, and then a potassium channel on the basement side as well. All right, and then intestinal secretion. So you have epithelial cells lining intestinal crypts. All right, so these are intestinal crypts. We have our villi coming up. You have our epithelial cells are going to secrete fluid and electrolytes. The basolateral membranes are going to have potassium, sodium, chlorine co-transporters, which are going to bring potassium, sodium, and chlorine into the cell from the blood. All right, so into the cell from the blood, and then chlorine is going to, so this transporter right here, is bring all three of these things into the cell, and then after chlorine gets in, it's going to go through a chlorine channel out into the lumen, which is going to cause sodium to overall follow into the lumen as well, but it's going to go paracellular instead of through the cell. And then as a result of chlorine leaving the cell, sodium passing through, paracellular, water is going to also follow into the lumen. And so you have secretion from inside the mucosa into the lumen overall. And so this movement of chlorine ions is going to result in sodium ions moving. Chlorine and sodium moving together is going to draw salt out as well. But generally, these chlorine ions are closed, but they can open in response to neurotransmitters and hormones, neurotransmitters such as acetylcholine or VIP, on receptors on the basement membrane, which is what we see here. The receptors will activate adenylyl cyclase, which is going to generate CAMP, which opens chlorine ion channels, and then diseases such as cholera are going to maximally stimulate adenylyl cyclase, therefore maintaining chlorine ion channels to be open, maintaining sodium ions to leave paracellularly as well, maintaining water leaving as it follows, so you get diarrhea from chlorea. All right, we're just about done. So talking about diarrhea, it's a major cause of death worldwide. Unfortunate, sad. It's a loss of you have a loss of extracellular fluid. As a result, a decreased extracellular fluid volume, decreased intravascular volume as a result, decreased arterial pressure. You have your baroreceptors and your angiotensin-renin system will try to fix this, but it can't do anything if there's already too much fluid loss. And then you also have loss of electrolytes. So if you have loss of bicarbonate, this will cause hypochloremia, aka acidosis, meaning too much chlorine, which really just saying is you've become acidic because you've lost bicarbonate ions. So nice medical term, hyperchloremic acidosis, but it's really just you had diarrhea and you lost a lot of bicarbonate ions. You can also have hypokemia, as we've mentioned a couple of times now. So different causes of diarrhea: decreased absorptive surface area. So basically you have extra fluid because it couldn't get absorbed because you've had a loss of surface area. And what would cause a loss of surface area? Decrease in microvilli, perhaps, as a result of infection and inflammation. Osmotic disturbances, aka a lot of non-absorbable solutes in the lumen. So think, starting in oncotic forces, if you have a lot of lactose in the lumen of the GI tract that could not be broken down due to lactase deficiency, now you have Starling forces bringing fluid into the lumen, and you're going to have diarrhea, so osmotic disturbance. And then secretory disturbance, so third cause, excessive excretion of fluid by epithelial crypt cells. Again, that's these guys right here, epithelial cells lining the invaginations along the GI tract, adjacent to the villi. And major causes, the overgrowth of bacteria such as Vibrio cholerae or E. coli, and basically steps are bacterial cholera toxin enters the cell, permanently activates adenylyl cyclase. We know that adenylyl cyclase is going to open the Cl chlorine ion channels, which causes chlorine to leave, which causes sodium to come out paracellularly, which causes water to follow. And so these toxins are going to permanently activate adenylyl cyclase, keep CAMP levels high, maintain chlorine ion channels to stay open, and to result in a lot of water coming out. All right, then we had our clinical correlations. Same thing. I'll let you take a look at them yourself. But that's the end. Good job, guys. That was super long, and my throat hurts because of talking so much. But good job, and another one done.